Hello, everybody. Good evening and welcome to BioMonde Live. Thank you very much for joining us. My name's Rebecca and I am the UK Marketing and Customer Service Manager here at BioMonde. And I'm delighted to be joined by Dr. Leanne Atkin, who is our expert guest speaker for this evening. So the webinar tonight is all about debridement and just why debridement is so important. So the session this evening is going to last for about an hour. We think Leanne's going to speak around about 45 minutes for you. The timings may vary ever so slightly, so do just sit tight and enjoy the evening. And we will set aside some dedicated time for you just at the end of the session for any questions that you may have for Leanne. Now, for those of you who are new to BioMonde Live, if you haven't joined on before, I am just going to get you acquainted with a couple of buttons which I think you're going to find useful as we go through the session this evening. So the first is the chat button, and that's going to be your space to network this evening and just to interact amongst yourselves. So just for some peace of mind, guys, we can't see or hear you. Your cameras and your microphones will be switched off for the duration of the webinar. So you can communicate through that chat function of Zoom, okay? And the second button to be aware of is just the Q&A button. And that links back to that question and answer session I just mentioned. So if you do have any questions for Leanne this evening, if you think of anything as we're going through the session tonight, do just press that button and type those questions in. What we'll do then at the end, we'll accumulate all of those questions and we'll hopefully get around to answering as many as we can for you. And you can see we've got some BioMonde social links there on the slide as well. So do please check those out. And if you are enjoying the webinar this evening, it would be great if you wouldn't mind just popping a little post up about it. So to introduce your speaker this evening, I'm delighted to be joined by Dr. Leanne Atkin. Leanne is a vascular nurse consultant and at the Mid Yorkshire NHS Trust, and she is also a lecturer at the University of Huddersfield as well. And I'm sure some of you will be familiar with Leanne already because she has done a couple of BioMonde Live webinars for us before, the first on peripheral arterial disease and the second on venous ulceration. Both absolutely brilliant sessions. So I do recommend after this evening, if you just go and have a little look at those, they are available on our YouTube channel. So let's have a look at what you're going to be learning with Leanne this evening. So Leanne is primarily here to talk to you about the importance of prompt debridement. But around that, you're also going to be learning to assess and diagnose devitalised tissue with accuracy. You'll be looking at optimal patient management via early intervention. Leanne will be discussing wound hygiene and debridement for an anti-biofilm strategy, and she'll be exploring pros and cons of various options for debridement that are available to you. And within that, we are going to be looking at some advantages, particularly of larval debridement as well. And lastly, Leanne is going to cover some pathways and guidelines for you just to aid that wound bed preparation. So that's it from me for now. I am going to stop screen sharing, Leanne, and that will just hopefully allow you to share your screen. And whenever you're comfortable, then just feel free to begin your presentation. But Leanne, thank you so much for joining us this evening. It's so appreciated, and I can't wait to see this session. Thank you.
Thank you. So hopefully you should all be able to see my slides now, and you should be able to hear me okay. Thank you for that lovely introduction. As Rebecca said, my name's Leanne. I'm a vascular nurse consultant at Mid York's NHS Trust. I have a title by the name of doctor, but that's doctor by PhD. I'm a very proud nurse. I am a joint clinical academic, but I'm still down and dirty in clinic on a Tuesday, Wednesday and a Friday. And Wednesday is double leg ulcer clinic. It's like double maths, if you remember, but actually it's my favourite day of the week. So I'm hopefully going to bring to you some of the academic side in terms of the science and the research, but also some of the practical applications of the reasons why and how you as clinicians out there can really start to improve your practice with debridement. I really like this title that BioMonde asked me to deliver because actually we really need to rethink what we believe debridement is and why we think this is so important. A lot of what we're going to talk about today is actually the movement of the science in terms of what we used to do to what we should be doing now. And a lot of what I'm going to talk about is based on this publication that I can't believe now is 5 years old, but we published this timers document back in 2018-19, talking about how we can improve healing for those patients with hard to heal wounds. And this document really talks about the fundamental aspects of care. It sets the scene of what you need to do to try to optimize wound healing in any patient that you're seeing, no matter what the underlying pathophysiology is. It talks about that early intervention. So let's treat a wound from day one as a potential hard to heal wound. It's about thinking about the accurate assessment and diagnosis. What is the underlying pathophysiology? Why has the wound occurred? How do we actually combat that disease or manage the reasons why? It talks about the optimal patient management strategy. So really bringing in that patient activation, the well-being of the patient themselves to try to get them involved in their own clinical decision making. It also talks about the appropriateness of skilled health professionals and actually how we need to escalate patients up and down our skilled professionals. And I believe that escalation is the marker of best care, not a marker of failure of care. And it really talks about when do we need to actually refer to specialists and who that should be and at what time scale. Unfortunately, it seems many patients only get to see by specialist wound clinics such as plastic surgery teams or vascular clinics when wound healing has failed to occur. And I mean failed in terms of that wound's been present for months and months. And I think that really we need to start to revisit that. And actually, if a wound hasn't healed within 12 weeks of therapy, then I think that patient should be referred earlier. But a key part of all of this in terms of this fundamental aspect of wound care is good wound management. And when I talk about good wound management, it's really thinking about that effective wound bed preparation. And the timers document stands for tissue, infection, moisture, wound edges, repair, and the social aspects of that patient. But today we're really going to focus on actually that tissue aspect in terms of what do you do if you've got a wound with devitalised tissue, wounds that you need to debride. And that's what we're going to focus on today. I just want to remind you what debridement is. We use the word a lot, but actually it's a French word. It means remove the constraint. And actually what you do most is you debride a horse. So you take the bridle out of the horse. So you are debriding that horse of that actual constraint. And that's where it comes from in the French language. But it's this amazingly attractive gentleman, Henry Ledran, who first actually used the word debridement within the medical term. And for us, it starts to think about removing that devitalised tissue. This humour document is now quite a few years old, but actually I love this definition of debridement because I really think it starts to encompass all that we're trying to do as clinicians. So debridement is defined as the act of removing adherent, dead or contaminated tissue from a wound and must be clearly separated from the act of cleansing, which is defined as removing dirt or loose metabolic waste material or foreign material. So it's about the removal of this adherent, dead or contaminated tissue. And that's what we're going to focus on today. So why do we need to debride? Well, the first reason is it helps to remove the physical barrier that's attached to that surface of the wound. That's going to actually impact that epithelialization. It may well increase contraction of the wound or actually as a hindrance to that granulation regrowth. But actually what you will find with devitalised tissue is that it is an absolute feast of a place for bacteria. So it's a huge bacterial burden that's on that wound. So there is an increased risk of actual infection. But the science has moved on more because actually what we know we need to do by removing that devitalised tissue is actually convert that chronic wound into an acute wound. We used to believe that be careful with wounds. Don't cleanse them too much, don't rub them too much, don't cause bleeding. All of that is bad. Well, actually, we know from the science, and we'll go through why that is, that we've moved on, if you like, and actually re-stimulating that wound healing cascade, so that causing that requirement of hemostasis, that acute inflammatory response, can start to stimulate and cascade that new wound healing. And all of this is what we're trying to do, is actually arrange coverage of that wound earlier, so to facilitate wound healing. It's like this picture that you can see here. And I do love this picture because many patients still say, should I leave my wound to dry out? And you can see what happens to a wound if you leave an open wound to dry out. It doesn't form a scab like you do in children when they graze their knee. You actually have this devitalized tissue becoming dehydrated and sat there on top of that wound. That then hinders that, or the movement of those cells to be able to facilitate wound healing. It also acts as a huge growth of bacteria. So we know from that moist wound healing that we should be trying to remove that devitalized tissue, getting that wound bed as clean as possible, allowing that granulation bud to come up and allowing those epithelial cells to start to skate over the top of the wound. But within the UK, debridement is really poorly done, especially within the UK. And we all know that wound bed preparation is key, and it's recognised by most nurses and podiatrists that we need to debride that wound. But when we talk about debridement, most clinicians believe it's about applying a dressing. But actually, I'd say that we could be doing so much more rather than just applying a dressing. And I do think that if you look at the evidence base in terms of what's happening within diabetic foot ulceration, where they regularly blade debride the callus and the wound bed itself, we're not using that knowledge and that emergence of science within other fields, such as the management of venous leg ulceration. Many people will not physically debride a venous leg ulcer, but actually, should we be moving that act forward based on the science that we've got? So debridement's two things. Callus debridement, we're not going to talk about that tonight, but I just wanted to put these slides up to say that callus debridement is a vital skill when it comes to wound bed preparation. It's a vital skill to actually stop the formation of ulcers and increase pressure. It's a vital skill to be able to determine what's underneath that. Is there a non-healing wound or not? Or in that other patient that you can see with a neuropathic ulcer underneath their first metatarsal head, your callus can actually form like a noose around the neck. And we need to remove that callus to be able to allow the pressure to be relieved and that wound to heal. But we're not talking about callus debridement tonight. We're talking about debridement of that devitalized tissue. So devitalized tissue comes in an array of different forms. It comes in sloughy tissue, which tends to be yellow. Over time, the yellow sloughy tissue can dehydrate and you can get eschar or necrotic tissue. And sometimes, like on that picture on the far left, you can get devitalized tissue as a way of trauma or hematoma formation in the base of that wound. And each of these wounds, we need to facilitate wound healing by removal of the devitalized tissue. So what is slough? You'll see it every day in clinical practice. You'll know that it comes in very different forms. This is classic slough that you can see within this slide. It tends to be pale yellow, adhered to the wound bed itself. And that slough is formed as part of that natural inflammatory process. It's normal for a wound to have a degree of slough on it. It will always hinder wound healing, but it is normal part of that wound healing cascade. If you look at that sloughy tissue underneath a microscope, you'll find that it contains a host of different things, including fibrin, white blood cells, bacteria, debris, dead cells, and different types of protein material within that. I say slough typically looks like that, but I'm going to show you a whole range of slides tonight of the varying nature of what slough can look like. Because slough can look from all the way from mozzarella cheese that's quite loose and removable, to snotty, stringy slough, to slough that is extremely adhered and looks slightly more darker in colour, sometimes even greyer in colour rather than yellow. With slough, though, that's part of the normal inflammatory process. The other type of devitalised tissue is necrosis. Also can be called gangrene or eschar or necrotic tissue. And this is dead cells. This is caused by a lack of oxygenation, a lack of blood supply to that specific area. And no form of necrosis can ever be reversed. We really need to think about removing that area because it's like being a plug of devitalised tissue that's stopping that wound healing from occurring. Initially, necrotic tissue can look quite thin and superficial. It can feel quite soft at times, but as it dries out, it can become very hard and very leathery, so much so you could tap it with a fingernail and it feels like you're tapping at wood, really. It can become so dry. I think necrotic tissue is worse than sloughy tissue because of the number of bacteria that will be involved in this. You'll often find when you have necrotic tissue, you've also got a significant malodor. That malodor is because of the anaerobic bacteria that's happening within that wound. And we can't stop to think about how bad it must be to live with a wound, never mind living with a wound with a significant odor. We ask these patients to ensure they've got a good nutrition, they're intaking a balanced diet. How would your appetite be if you could just smell necrotic tissue on yourself? The problem is with this as well as it starts to actually debride through natural autolysis through your body, you can find that the exudate levels start to increase, the odour starts to increase, we have this huge barrier in terms of cellular growth, and really worryingly with necrotic tissue, you don't know how deep that wound is really going. It's that Titanic tip of the iceberg, if you like. You don't know whether that's just 0.5 centimetre that you'd be able to blade debride off, or you don't know actually if that's going all the way down to the bone. The one thing I just want to remind us of, though, is when we're talking about non-healing wounds. So a non-healing wound versus an acute wound cellularly look identical. They've got the same type of makeup. They've got the same type of cells that's trying to activate this. The only difference is the wound that's healing between a wound that's become chronic or non-healing is two things. It's an increased amount of MMPs caused by that chronic inflammatory cycle that wound is stuck in, along with the increased amount of biofilm that's on the wound. And we now know from the science that around 80% of non-healing wounds have actually got a biofilm, and it's probably the biofilm that's causing that wound to stall to heal. The wound colonisation continuum has changed over the last decade, and we now really have a clear distinction between actually contamination and colonisation is normal and actually will not impact on wound healing. We can get localised infection, so the host is not getting a response, but you've got a high amount of bacterial burden on that wound bed, such as Pseudomonas infections, and they might need treating with topical antimicrobials. But once we get spreading infections or systemic infections, we need to be thinking about our antibiotic therapy. But actually just look at that continuum across the top in terms of biofilm. You can get biofilm ranging throughout all of these wounds. And it's the biofilm that's actually going to impact that wound healing. And this is why many times you will take a wound swab and you'll find that you are growing some organisms, but that's just colonisation of that biofilm. It doesn't mean that patient requires antibiotics. They only require antibiotics if there's signs of spreading or systemic infection. A biofilm is a really interesting thing. A biofilm is a group of different bacteria that start to actually provide a colony together. when they start to provide this colony together, they excrete this substance called EPS. And I like to think of EPS like treacle, if you like. So they start to form in this treacle, and that treacle does two things. It attaches them to the actual wound bed, but it provides a protection over the top of the bacteria. And this gives those bacteria a great environment to reproduce, to recolonize, and actually to continue to impact on wound healing. And when a biofilm becomes mature, which can happen after only 24 hours, then it really starts to impact because it increases or stops that wound moving forward, so it gets stuck in that chronic inflammatory cycle. You get increased amounts of MMPs, you get increased amounts of exudates, and this all causes cell senescence. So the cells basically go to sleep. And I like to think of these biofilms, if you like, in this protective dome. Have you ever used a silver dressing on a patient with Pseudomonas and found no effect? And that's because the actual Pseudomonas bacteria is sat within this protective bubble of this biofilm. So no matter what you do or what you put on top of it, you can't actually penetrate down to that bacteria. So the silver looks ineffective because the Pseudomonas continues to be profound. It's only actually if we start to debride those wounds, so exposing that bacteria, removing that biofilm, then we can start to think about killing off that bacteria that's causing that wound to become chronic. You can't see a biofilm with a naked eye, but you certainly can see the clinical signs of a chronic biofilm infection, and all of these are that really superficial fluffy tissue that you want to sort of pull off in strips. That's a mature biofilm. That chronic Pseudomonas that you can see from that bright green exudate within those pictures, that's a chronic biofilm. And no matter what type of antimicrobial you're using, that biofilm and that Pseudomonas is protected. So you're not actually being able to eliminate that. We often say that if you have got slough that you're able to debride and then it reforms really quickly, think about whether that's a biofilm. If you've got that granulation tissue that's extremely fragile, so you touch it, it can bleed in an area just from simple touch, it's probably because of a biofilm. If you've got that wound that's just showing those chronic low levels of inflammation with small amounts of erythema around that wound bed, but no true host support response, it's probably about that biofilm. And we need to think about actually, how do we move these wounds forward? So if we have this wound with this devitalised tissue on it, we know that non-healing wounds are an ideal environment for the biofilm to come. We know that if biofilms come, it causes that chronic inflammatory response. That chronic inflammatory response leads to sloughy tissue and delayed wound healing. And that if you've got delayed wound healing, you're more likely to get a biofilm. The biofilm's more likely to cause inflammatory response. And you can see why we get stuck in this cycle of having these patients with a wound like this that you just don't seem to be making any progress with in terms of moving that wound towards wound healing. We're going to put a lot of links within the diagram, within the sessions tonight at the end of it, so you'll be able to look at all of these documents that I'm referring to. But I think the greatest thing that's happened recently is this wound hygiene, and it talks about strategies of what we can have to actually prevent the formation of biofilm. And it's thinking about when we debride, how quickly we debride, and actually how do we think about an anti-biofilm strategy going forward to try to break out that cycle of that chronic inflammation. So hopefully I've presented with you the real clear reason why we need to debride these wounds. But actually, when it comes to debridement, what options have you got? And there are many options that you've got available to you. But you've got to remember, I like to think about a wound with any devitalised tissue as being in that negative stance. So we're on minus days or minus weeks. And you can only actually start wound healing if you can get that wound from fluffy tissue, devitalised tissue to clean. That's sort of 0.0, and then wound healing can occur. So when we think about debridement, the one thing I want you to think about is speed, because we've got lots of options available to us, but how do you go about choosing those? So we need to be thinking first off about speed. If that wound is not going to heal until we debride that wound, how quickly can we get that wound bed to clean? We also want to choose something that's very selective. In other words, that will protect those healthy granulation buds that may be underneath that superficial fluffy tissue. We don't want to damage those. So how can we protect those at the same time as debriding that devitalised tissue? In an ideal world, you want something that you can use both on that fluffy tissue and on that necrotic tissue, because quite often you get wounds with different types of slough or slough and necrosis together. But we also want something that's easy to use, easy to access, overall cost effective, and acceptable to our patients. I like this little table that's quite old now, but it's from the Canada Wound Association. And it really just starts you to think about where are your advantages in terms of the debridement options that you've got. So I just want to go through those options that's available to you in your clinical practice, just to get you thinking about which you should be choosing in future. So the first one is autolytic debridement, and this will be your go-to. I can imagine this is what happens in 99% of your patients at this moment in time. And when I talk about autolytic debridement, it's simply the application of a dressing. Autolytic debridement happens naturally through autolysis. So if you had a tiny little bit of fluffy tissue and you are well in yourself, your body will get rid of that without any form of wound dressing. What happens is that the body pulls through to the surface of the skin extra enzymatic fluid through that dermis subcutaneous tissue onto that epidermis, and that slowly pulling through of this enzymatic fluid starts to debride that fluffy tissue. All of the wound dressings that you currently use just enhance that process, and they'll enhance that process by two methods. Either number one, they'll add extra moisture to increase that process, or they'll provide a greenhouse of protection, so keeping that moisture that comes through on the wound bed for longer periods to facilitate that autolysis. Autolytic debridement is good because it's easy to do. Anybody can do it who can redress a wound. But I have a huge problem with autolytic debridement because it is so slow. You think about these two wounds that you're seeing here. If you chose to debride this with any of the dressing that's available to you, some form of hydrofiber or some form of honey dressings or some form of gel dressings, how long would that take in terms of getting that wound to debride? You're not talking days, are you? You are talking weeks before you get that wound to debride. And if you believe that that wound is in a negative state, you are just spending weeks and weeks to get it to 0.0 to allow it to heal. I also think some of the wound dressings, when we start to debride, especially when we start to debride necrotic tissue, we can stimulate that bacterial response, and therefore we increase the risk of infections for our patients. The second one, which is the one that I tend to turn to first, is surgical or sharp debridement. And for this, we tend to use curettes. It's relatively quick. It's cheap, so long as it's done out of a theatre environment. You can be selective if you've got good hands. However, there is a degree of competency required. There is a need for some formal education and some sign-off of additional competencies. And I get that for a lot of clinicians, actually picking up a blade, there is a big fear factor. And I get that fear factor, because actually, if I look at that wound, I may well have the confidence to start to take a blade to debride that. However, I know that anatomy below that tissue. I know where the arteries, the nerves, the veins run. I know where the tendons are likely to be. And actually, that's really important in terms of that surgical debridement or sharp debridement. And that's why for many wound care practitioners, sharp and surgical debridement is really not within their current scope. I think we have to acknowledge, though, that the debridement pads that's out there can really help. So the debridement pads, often monofilament pads that you can actually start to rub onto that wound, will lift some of the devitalised tissue and also lift some of that biofilm. They are relatively easy to use, they're cost effective, they can be used in any type of environment that's out there. The difficulty is with them, I don't think they are ideally suitable for all types of non-devitalised tissue. So you can see that superficial fluffy tissue on the amputation site. They may well pick up some of that stringy, snotty stuff at the top end of that wound. They certainly won't be able to do much for that very adhered, fluffy tissue right at the base of that wound. And they'll make very little impact in terms of that devitalised tissue, that necrotic tissue / fluffy dehydrated tissue. They're not going to make any impact for that whatsoever. So I think they have the place, but to me, it's only for very superficial amounts of devitalised tissue that's relatively not well adhered. I do think curette debridement is the thing that's going to be in a lot of the future, and this is relatively easy and cheap to do. I think giving a nurse a scalpel, they always get twitchy. Giving them a ring curette sometimes can make it feel more safe. It costs pennies, they're about 54p each. And you can debride a wound like this, that pre-picture, that post-picture. You can see how you've got rid of the devitalised tissue. You will have disrupted the biofilm, and you've kicked that wound from that non-healing state into that acute healing state. And I must say, it's the most satisfying thing that I do in terms of removing that tissue with a curette. I find them difficult to do any harm with, but also I do understand that they can cause bleeding. And I think it's very different for me to be able to control bleeding in a clinical setting than controlling bleeding in a home setting. But what I just want to point out really is that the science is there to really talk about the debridement, and actually maybe using our debridement skills more and more where we possibly can. Simple sharp debridement can stimulate healing in chronic wounds, and this paper showed that it's safe, well tolerated, and can easily be performed in an outpatient setting. And simply by debriding a wound on a regular basis with a curette, you can find that you will stimulate wound healing 3 times quicker than what you can by non-debridement. And it's simply that activation of those cells. You are moving that wound from that sleepy state, if you like, to actually kick-starting that wound healing. But again, it has to be recognised that curette debridement is only suitable on certain wounds. All of these wounds that you can see here, even if you are a master with a curette, you're never going to actually get to a clean wound bed. And I say that because each of these wounds are very undulated. They've got pockets of depth in certain areas, which is really difficult to get to. They've got mixed type of fluffy tissue. Some of that is that soft and snotty tissue. Some of it is much harder, well-adhered tissue. And some of that has got signs of Pseudomonas colonization in terms of that amputation picture at the bottom. And I think when we're talking about these wounds, this is where larvae therapy starts to actually play a significant role. Larvae therapy is really good. It's got huge amounts of evidence to say how effective it is. But actually, it's the most selective method of debridement that we've got. There are some cons. You know, the biggest con is the time delay. That if you want larvae today, you have to order it today, but you won't get it until tomorrow. People say that larvae is expensive. I do not think it's expensive when you look at that overall picture, because one bag of larvae therapy may cost more, but I will simply say to you, if that gets you to week 0, surely it becomes cost effective. Because if you don't use larvae therapy, you might be using things like hydrofibers and honey dressings for weeks / months before getting to that clean wound point. And all of that is a significant amount of cost, not just product cost, but your time. I think the acceptability of larvae has also increased greatly. We used to previously use loose maggots that you can see within that picture, and there was always a fear factor of the patients of escapees. I think now that the maggots have come within the tea bag, so therefore you cannot lose a maggot anywhere, the patients find them much more acceptable because they're no longer feared about losing those maggots. I must say, I think that they're amazing little things. So the larvae therapy that BioMonde use comes from the green bottle fly. And we've used this widely within medicine since 1920. It slightly got less of use when antibiotics were introduced because they sort of were seen as the saviour. But it was reintroduced back into wound care in the 1980s, and within 1995, within the UK, it became readily available to us. And it has huge advantages. They're extremely rapid at debriding that devitalised tissue. They're selective, they're very easy to use. It requires very little skill in terms of application. We know more and more that the actual secretions from the larvae is the thing that is magic. It's magic fluid because it helps to debride the wound. We know that it helps to reduce the bacterial burden, including MRSA. We know that it starts to reduce that chronic inflammatory response within the wound, and all of that starts to promote wound healing. You put them on and the tiny little things, by the time they come off, the size of a fishing maggot. There's many myths. So one of the myths that I commonly hear is you can't use larvae therapy in patients where there's Pseudomonas because the Pseudomonas will kill the larvae. You can see in this gentleman here, there is Pseudomonas contamination, and the larvae therapy loved it. And you're able to take a wound that we've done some blade debridement of, but you were still faced with a very devitalised looking wound bed. One application of larvae therapy, you can go to a wound bed where you can see you've removed a lot of that devitalised tissue, but you've also done something else. You've started to stimulate the growth of that new granulation tissue that you can see. We've used it on patients where they've had significant trauma to their feet, and I would never be brave enough to take a scalpel to that because I know the structures that's underneath that. But actually, one application of larvae, you're already getting rid of a lot of the devitalised tissue. The second application of larvae, you're all the way down to that new healthy tissue. But you've been able to protect those structures. You can see the tendons are visible, but actually the tendons are still viable. If a surgeon would have taken a knife to this, they may well have disrupted that function of that tendon and therefore the function and the long-term outcome of that foot. So what we're saying within larvae therapy is that it's not for every time that you have devitalised tissue, but there are certain patients where actually larvae therapy holds some great advantages to you. So we encourage you really to think about using a debridement pathway. This is one that BioMonde has developed. And I really like this because it starts you to think about the urgency of debridement. And that's the one thing I want you to take away from this session today. What is the urgency in your specific patients? We have to think about the risk to the patient of having that non-healing wound, the risk of infection, the risks of needing further revascularization or operations, the actual bioburden itself, trying to actually reduce those microorganisms and that biofilm that may well be impacting on wound healing. It's thinking about what's the consistency of slough. If it's thin and shallow, maybe that debridement pad may work. If it's thick and well adhered, you need to be thinking of other therapies. We've got to remember that the devitalised tissue is a physical barrier towards healing and a breeding ground of that bacteria. So the sooner we remove it, the better. And we also need to think about, and many patients, especially those with pressure injuries, how do you determine the depth until you actually debride? How do you know what your treatment should be until you understand the size of your problem? And if you would like to contact your BioMonde local rep, they will be able to help you with this. So they are not saying that larvae therapy should be used for every patient with a devitalised tissue where debridement is needed, but they're simply saying we need to be thinking about when is fast debridement required, and actually what's the role of larvae therapy within that. And they can help you design your own local pathways and your own local formularies where they can say where we should be using larvae therapy, first line, second line, third line, or even not at all. The actual science and evidence base for larvae therapy is massive. It's probably got one of the biggest evidence base of anything that we do within wound care. There's over 2,000 articles published on this. There is proven science in terms of how effective it is at debridement and preparing that wound bed for healing. There's evidence of that bacterial reduction, including that reduction and eradication of MRSA. We know more and more about the larvae secretions stimulating granulation growth faster than any other therapy. And we know that they are hugely effective in terms of breaking down that treacle, in terms of that EPS that's holding that biofilm in place. And I really think that this quote from Gammon summarises it all, that larvae therapy has a seemingly unarguable ability to inhibit and degrade bacterial biofilms associated with impaired wound healing. And if you go back to the beginning of my slides, I said to you there's only really two reasons why a wound doesn't heal. Number one is biofilm, and that's going to be present on 80% of the wound. And the other is that stuck in that chronic inflammatory cycle. Larvae therapy has evidence to show that it's able to move a wound for both of those factors in terms of moving forward. When I talk about debridement, though, I have to always talk about when we shouldn't be debriding. And when you shouldn't be debriding, number one is patients with digital ulcers caused by critical limb ischemia or chronic limb-threatening ischemia, such as these pictures here. We also need to be careful in patients with pyoderma, because actually debriding those wounds can just make the wound bigger. We also need to be thinking about, is there a patient any evidence of underlying vasculitis or calciphylaxis, because both of these things need to be managed systemically rather than just debridement alone. There are some patients where caution is needed, and this is not a direct contraindication. I'm not saying you shouldn't debride these patients, but we need a little degree of caution. We need a degree of caution if that patient's got a bleeding disorder or is on any form of anticoagulation therapy. And actually, the one thing that I haven't mentioned so far today is we really need to think about that patient's pain and their tolerability of that debridement. I'm not too sure how I would feel if somebody came towards me with a scalpel and a blade and said, I'm just going to remove some of your devitalised tissue. I'm not too sure I would feel if somebody even came with me with a curette and said that they're going to scrape away the devitalised tissue. I think we need to understand that patient's pain more and think about their tolerability. Larvae therapy causes no pain and no discomfort to our patients. It's something that we need to consider. But prior to any form of debridement, a full holistic assessment must be undertaken, especially in patients with critical limb ischemia. If you have toes like this, Mother Nature is doing the job for you. We don't need to be encouraging debridement. We shouldn't be managing this patient with debridement products. We should be just trying to keep those toes as dry as possible, not allowing bacteria to start to flourish. Because in toes like this, Mother Nature will do the job. They will eventually auto-amputate, and actually Mother Nature will form a line between that vital and devitalised tissue. So caution is needed in any patient with peripheral arterial disease. We also need a degree of caution in terms of recognising when patients have infection. All of these patients have got devitalised tissue, but it's on a background of significant localised infection, which will cause systemic infection if not treated well. All of these patients are diabetic patients and have got diabetic foot infections. So we need to be ensuring that we are treating that devitalised tissue in combination with antibiotic therapy, potential surgical debridement, and even potential revascularisation. So if you've got any patient where you've got a wound on the foot, my caution to you is please think about that involvement of that wider MDT. The foot itself has got lots of bones, lots of joints, lots of muscles, lots of tendons, and the blood supply down to those little toes and onto that foot is complex. And we need that wider MDT to try to optimize that wound healing in that patient. But just to finish, really, I just want you to think about if this was your patient. If this was your patient and a seemingly easy to heal wound, you can see that that patient's got some devitalised tissue. That's in a negative stance. You're on minus weeks. We need to get that wound to 0.0 in that middle picture to allow wound healing to occur. And the most important aspect is time. We need to be thinking about how quick can we remove that devitalised tissue to get it to that wound healing, where the wound healing bed is perfectly prepared for wound healing to come. So rather than just always turning to wound dressings, think about that speed of debridement, think about what other products are available to you. Wound healing and wound delays in wound healing, there's never a simple single factor. There's often many contributing factors at play. But every wound that you're seeing out there that is not healing will have a very similar cellular response. There will be high levels of proteases, elevated inflammatory markers, low growth factor activity, and reduced cellular proliferation. Good wound debridement helps to cure all of those things. It really helps us in terms of aiding that wound healing. So, is it time for a change? I'd like you to think about where you are in terms of your optimal wound healing. Do you assess patients in a timely fashion? Are you able to ensure that you've got that accurate diagnosis? Are you good at wound bed preparation? Are you able to offer your patients speedy debridement to get them to 0.0 as soon as you can? What is your management for a biofilm? If 80% of wounds out there have got a biofilm present, how are you managing that at each and every dressing change? And I'd really like you to start focusing on wound healing. I hate the fact that many nurses tell me they're good at wound management. I don't want you to be good at managing wounds. I want you to be good at healing wounds in combination with your patients. Because actually, it's only when we start to focus on the time and focus on the healing can we start to actively prevent chronic wounds in the future. Thank you so much for listening. I hope you found that interesting, and hopefully we've got some questions to answer.
Thank you so much, Leanne. That was a really brilliant presentation. I loved it, and I hope everybody at home did as well. So yes, there are a few questions that have come in. So let's have a little look. And at this point, I am going to invite everybody, my colleague Vicky Phillips, onto the call as well. Vicky is the clinical support manager at BioMonde, so she can answer any specific queries surrounding larval therapy. Okay. So the first question that's come in is your thoughts on using medical grade honey dressings as an alternative solution compared to silver dressings.
I think antimicrobial dressings all have their place, and it's really interesting that my first thought about honey is an antimicrobial dressing. I think they all have the place. I think that they can all be overused. Me personally, the problem I have with honey dressings is that I do find that they can tend to increase the levels of exudate. And you might combat that with, well, yeah, because they're starting to impact wound healing. And when you start to impact wound healing, you might get an increased exudate level. I get that. But the thing that really sort of bothers me with honey is patients can find it painful. And I don't understand why. And I don't understand why 50% of my patients, I can put it on and they get no pain whatsoever. And 50% of my patients are pulling it off within a few hours. There are talks that it changes the pH of the wound bed and that might actually bathe the nerve endings, causing that pain. I don't use much honey in my clinical practice because I don't like the fact that I could give a therapy to a patient that they're going to find painful towards the end of that day. That just bothers me as a clinician, that it's just not something that I do. I'm not saying it's not a bad product, But I would say my use of antimicrobial dressings have gone down significantly since I've started wound hygiene. Good wound cleansing, good wound debridement, actually you reduce the need for antimicrobial dressings. And my silver spend has gone down by about 3/5. So it's gone down significantly. And we used to have problems all the time in our leg ulcer clinic of chronic pseudomonas that we could never get on top of. And we were just chasing it with various antimicrobials. We hardly have any of that now because all of my team actively cleanse and debride every single dressing change.
Brilliant. Thank you for answering that one, Leanne. So the next question that's come through is regarding debridement options. And this person is asking, have you had good experience with mechanical debridement using products such as Debrisoft or UCS cloth? And they've commented that they think these are a cheaper option for trusts who have a lesser budget or in the community when this can be done by community nurses on their rounds.
I hate naming products, especially competitor products when I'm on these types of calls, but I will tell you how it goes in my clinic. Every patient gets a UCS wipe in my clinic, but truthfully, I use that more as a cleansing wipe for the leg and the surrounding tissue to hydrate that and pick off the surrounding skin. Using them on the wound bed itself, can be useful. Along with mechanical debridement pads, they can be useful. But it's only useful, I think, on certain types of sloughy tissue. And I think it's that very, very wet mozzarella cheese type slough that's quite loose in the first place. And absolutely, if you've got that type of slough, I won't be turning for a bag of larvae therapy. I would just be doing mechanical debridement to getting rid of that. But if you remember those pictures that I showed you with all the different types of slough in different areas and different depths, that to me is a sweet spot of the larvae therapy, because no mechanical debridement pad is going to be able to do that. I know that they do the lollies to get into the hard places, but again, it's only good really on that superficial wet sloughy tissue. Once that sloughy tissue starts to dehydrate and it's so well adhered to that wound bed, you can't get it off with a debridement pad. You struggle to get it off with a curette.
Oh, lovely. Thanks, Leanne, for being so honest on that one. So the next question that's come through, this could be for both of you to answer actually, and it's what can be used to hydrate a dry wound in preparation for larval therapy? And they're also asking about wounds that might have a mix of that wet and dry tissue that you mentioned, Leanne, and they've said, could those wounds benefit greatly from larval therapy?
So I'll take that first, then I'll hand it over to Vicky. If you've got a mixed bag, so at least 50-50 sloughy and necrotic tissue, I won't bother rehydrating it. I won't bother worrying about rehydrating the necrotic tissue part. You can get your larvae therapy on, and actually the exudate that comes from the larvae feeding off the wet aspect of that wound will start to debride that other aspect at the same time. So I wouldn't be overly bothered. If you have a whole load of necrotic eschar, that is not the time for larvae therapy. They want something to feed on, and sometimes it can be just too hard for them to get through. There's lots of things that you can use. In my clinical practice, I use a combination of wound gels that you can put on to hydrate it just for 24 hours. The one thing is make sure you wash them off well, because some of them can be toxic to the larvae therapy themselves. The other things that we can use is stuff like the gel dressings that can help to rehydrate a little bit, or the ones that contain high volumes of Ringer solution where you can actually wash the wound bed through. But anything that you're going to donate wound water, well, you're going to donate moisture to the wound bed, anything will do. You probably only need it for 24 hours. So actually, if it's that dry, order your larvae therapy today, get some of that rehydrating on right now. By the time your larvae comes tomorrow, your wound bed's probably going to be suitable for it. You just have to increase your knowledge of what type of devitalised tissue you're looking at, because there's ranges of this. If it's a big, thick plug that's hard as anything and you could sort of carve it like a candle, you might need 3 or 4 days of rehydration. But most wounds that we're talking about tonight will be just a really small amount of necrotic tissue that actually, if you can go put a blade in the middle of it and you can see the redness coming through the middle of it, 1 day of rehydration, you'll be all right with your larva.
Brilliant, thank you. Vicky, do you want to add anything to that, or? Happy?
Not really. I think Leanne covered it. I think the most important thing to just reiterate is that there's a lot of people who think that if you are having to soften the necrosis before you put larvae, that you have to have a rest day, but that's not the case. Just a really good wash with some saline, sterile water, whatever is enough. So yeah, like Leanne said, if you think it needs something, then just overnight whilst you're waiting for the larvae to come is usually the perfect amount of time.
Oh, wonderful. Thank you both.
Yeah.
The next question that's come through from Paula, she's asking, where can she find training for sharp debridement, please?
So there's multiple options of sharp debridement. Here we are name dropping again. So probably the best course that's available at the moment is run by Accelerate. So they're a private enterprise company, but do NHS work mostly. And if you just look at their website, Accelerate, you'll see that they've got a debridement course. They use some really good wound models that's designed at the University of Huddersfield, so actually you can feel the different tissue layers, and that's a really good one. I know Wound Care Today often have a debridement session within their conference, so that might be worth looking at too. And there is also some cadaver training. So there is a company, Smith and Nephew, that actually they enable you to do some cadaver training down in their facility. So actually, you work on limbs of dead bodies. That can be really useful. The problem is with that, though, they don't bleed. And I think that becomes the difficult thing. But it is a good way to see different types of devitalised tissue. There are competency frameworks, though, because there is no requirement for you to do a formalised course. You can learn this in-house. So if you've got somebody who you debrides within your team, they can teach you how to debridement. And there are competency frameworks around that. If you look at wound hygiene competency framework, it talks about competencies of using mechanical debridement and sharp debridement, and you can do those in-house. So there's plenty of options for you.
Lovely, thank you, Leanne. And exactly the same question has come through for the curettes as well, with competency and training requirements. So would it be a similar route?
Yeah, all of them. Accelerate and Wound Care Today all cover curette, along with, so does the wound hygiene competency framework, they all cover curette.
Lovely, thank you very much. So a question for you, Vicky. Can anyone request or initiate larval therapy?
That is a good question. So although it is a prescription product, so it does need to be, because it's unlicensed, it does need to be an independent prescriber who actually writes it up. I don't think that means that you have to wait for the independent prescriber to suggest it. I think it's really important, if you think your patient is suitable for larvae, to ask the question, because the worst someone's going to say is no, it's not suitable for this patient. And you've got to remember, the independent prescribers, most of them, you know, they've got a big workload. They're not necessarily going to be able to see all the patients who are suitable for larvae. So yeah, I think it is always worth asking the question, even if it's not you that makes the final decision.
Lovely, thank you. And a very similar question actually from Tracy. She's had concerns in the past with the process being slow in requesting larvae from a prescriber to the point of application. And she's wondering, would she ever be able to prescribe as a non-medical prescriber? I think the answer is no to that, isn't it?
Only if she's an independent prescriber. So yeah, nurses can do the independent prescribing, podiatrists. We've even had a physio not long ago prescribe it. So if you've got your independent prescribing qualification, yes, you are covered. But yeah, otherwise you'd need to find someone. So it's a really good idea to go away after sessions like this and find out who's covered in your local area to write it up.
Brilliant, thank you. And a question now, probably for both of you. So Sunita has said she's a little bit hesitant with using larvae just due to pain levels. She's had situations in the past with patients where she's actually had to discontinue the use due to pain levels. Have you got any advice for her, please?
Well, I found that really interesting because I've never had that with my patients. I've had some patients that's got a bit bleedy and oozy with them as a side effect, but I've never had any patients where pain has been the issue. I can imagine the patient that she's talking about, though, may well have a degree of oversensitive neuropathy. So what they're finding is actually that the movement of the larvae is stimulating the nerve endings that's giving the pain. And those type of patients, any pain management is really difficult to be able to get right with them. But certainly she's doing the right thing. You know, if any form of therapy is increasing a patient's pain, that therapy needs to be stopped from my point of view. It's just not appropriate, but it's not something I see or have heard of in my clinical practice in terms of the larvae. Many of them don't like it. Many of them tell me that they can feel them moving and it feels like they want to itch the hair all the time. But none of my patients have reported increasing pain. Vicky, is that something that you see?
We do occasionally. I think the main thing to remember is that with a therapy like this, it is a bit different. And I think it's really important just to spend 10 minutes talking to your patient about any queries, concerns, things like that they might have. Because movement, like you say, Leanne, it is a bit weird. It's a bit uncomfortable. And if you're not expecting it, it can be quite anxiety inducing. So if you can just spend sort of 10 minutes before you apply it, explaining to your patient that as they get bigger, you might feel them, but it's totally normal. Also talking to them about how the larvae feed. So explaining to them that they don't bite because they haven't got any teeth. So you're not going to feel anything munching or crunching. And I really think, you know, just spending a little bit of time with patients before can really help them when they do get some sensations to be able just to cope with it a bit better.
And you know, us understanding that is really important, Vicky, because you know, I'll always remember the time that you put the larvae into the bags. And I was like, well, how are they going to feed? How are they going to work now? And I really did believe that the larvae had teeth and they chowed down. And you know, and it was only through doing your education through your company that I realized that these are straws. And what they do is spit in enzymatic fluid that kills the bacteria and dissolves the devitalised tissue. And then they suck it back up again, and that's what they ingest. But you know, once I got that, I thought that really helped me explain it to my patients that actually they're not going to chew on you per se, because actually they're in a bag. All we're using basically is their spit to dissolve this down. And I often think with the movement thing, though, I'd love to do a study. I'd love to do a study of actual larvae that's alive and larvae that's dead and ask, you know, 50-50, can you feel it? Because it's the same thing. If you're next to a mother and that mother says, my child's got head lice, you instantly want to itch your hair. And it's just something in you that, look, it's there, it's itching now, just talking about head lice. And I often think, is there a degree of that within the larvae therapy? And I'd love to do a study to understand that more.
Definitely.
Brilliant, thank you both. And we've had a little flurry of questions actually just around the daily care processes for larvae. So we'll do these ones quite quickly, everybody. So the first question that's come in is, can larvae be used in the community?
Yes.
Yeah, brilliant. The second one is just about securing that biobag down onto a wound bed. So have you got any tips and tricks for what secondary dressings to use and the tape and things like that to secure the bag in place, please?
So from my point of view, it depends where it is. You know, if you've got a cavity and that cavity, let's say, is on a thigh, on the top of your thigh, you don't need to secure it with anything. Put the larvae in the cavity, put some moist gauze over the top of it, a bandage or retaining something, you're on a winner. The difficulty comes, let's say, if it's on the sole of the foot and you're holding that on and you're needing to rehydrate them every day, and you don't want that bag to fall off, because if that bag falls off onto the carpet, you've lost all of that cost. You might want to secure it just with some form of tape, just a thin layer of tape just over the top of that bag to keep it in that position. But all of this depends on the location, the surrounding skin condition, and how much exudate is coming from that wound. I would just say it goes back to just your common sense. You'll know what to do with these. It's not rocket science, and you can't go wrong, is what I'd also say.
Brilliant. Thank you very much for answering that. And just to close then on the point of the sort of daily care processes, we've had an interesting question from somebody in Germany. They have heard in the past that you need to turn the biobag around on the wound bed twice, which I've never heard before. So
that
if you two
was
wouldn't mind.
something we used to do when it was biofoam, I believe, a while ago, because the way it was sort of made up, you had lots of little chips in it, so you had to make sure that the larvae could get to everything. But yeah, with the biobags, You don't have to worry about that. If anything, you're going to put them on the back foot, because the way they work, they'll all be sort of face down, as it were. And if you flip them over, they then all got to turn back round again to get to their food source. So yeah, just leave them well alone. They'll be fine.
But that
Lovely.
person's not going mad. I've heard that before.
Yeah, no, it is.
I've heard that we've had to not flip them twice, but flip them once. And every time
Yeah.
you rehydrate them, you should flip them over.
Yeah.
And I've even asked that question. I went, where's that come from? And the answer is no. All you need to do is just rewater them. That's the only thing that they require.
Oh, brilliant. So some nice updated education there. Thank you both. So just moving back now quickly towards debridement in general. So the question here is debridement enough for treating a wound that shows signs of Pseudomonas with that blue or green drainage? And should it be followed with antibiotics or an antimicrobial dressing as well?
So, first off, no antibiotics needed. That's an easy one, unless they've got a systemic infection. Absolutely, we don't treat localized Pseudomonas with any form of antibiotics. Larval therapy are effective at eliminating Pseudomonas. However, Pseudomonas can be persistent. So if you are debriding with larval therapy, and you've used one and you've gone from 90% sluffy tissue down to 10% sluffy tissue, you may well still have a residual Pseudomonas remaining, and then you could swap to an antimicrobial dressing just to carry on your little bit more debridement and get rid of that Pseudomonas burden. Or if you've got a huge amount of Pseudomonas burden, what you might decide to do is to treat with some antimicrobial therapy whilst your larvae is on order, and then swap it back over. And Pseudomonas is a persistent devil, is what it is. So it's very unusual that you can treat it just once. It often requires a course of treatment over a number of weeks to be able to get on top of that Pseudomonas. But the one thing that's really good for Pseudomonas is good wound hygiene, good cleansing, and regular debridement to get rid of it.
Lovely, thank you. And the last couple of questions now, ladies, before we close the Q&A session. So the first one is, what is the level of sterility expected for bedside or clinic-based conservative debridement? And they've gone on to ask with questions, clean technique or sterile procedure?
Oh, here we go. And I wonder if this person's in the UK. To me, it's a clean technique. And it's a part of your ANTT non-touch. And if I was doing some form of debridement, I would certainly do my ANTT approach. However, I have to say that, and I think if I wasn't debriding, I think ANTT in patients with leg ulceration is extremely difficult, if not impossible to do. So I think that we really need to be forcing back on this infection control, because actually what we really need to do with these patients is wash their whole leg, debride those skin cells, re-moisturize. And, you know, I still believe in the use of buckets of water, you know, not soaking for a long time, but actually cleansing that skin and that surrounding tissue. I think this is an infection control debate to be had, but in my practice, it's a clean technique.
Lovely, thank you, Leanne. And the last question of the evening, how good or bad is fluorescence usage in wound care?
Well, who knows? It's an emerging science, and it's something I've certainly got my eye on, because you know, if I could have a bedside test to be able to show what's the level of bacteria, where is that bacteria in the wound bed itself, I think it'd be really useful. I've seen a lot of the studies, and I've seen a lot of them in terms of showing how some therapies you can really see your action there and then. The difficulty is with it is it really showing you what you think you're showing? And actually, how easy is it to use in clinical practice? Because you need a very dark room. And most of our clinical rooms have got daylight of some description coming in by a frosted window, and that can make it really difficult to use. I am interested. All I'd say to you is, though, I have bought a device and I hardly ever use it. And that sort of worries me, that if I have that tool, if it was so valuable to me, would I be using it more and more? I think it's great for an academic, and I think it's great for research and science. I'm not too sure how valuable it is in everyday clinical practice. But my eyes on that space, and I am open to be turned if the science shows me that it's good in the future. So I think just watch that space. It's an unanswered question at the minute.
Oh, definitely. We'll wait and see. Thank you so much, Leanne, for answering those questions. And thank you to everybody at home as well. Really brilliant set of questions this evening. So thank you. So if you've enjoyed the session this evening, everybody, you can find more BioMonde Live webinars on our website. We have mapped out basically the entire year for you. So if you do want to register for any of those, please go ahead and do so. And we do have some other learning options for you as well. So we've got BioMonde Now, which is our online video portal. We've got BioMonde Academy, which is bite-sized e-learning modules. And lastly is BioMonde Direct, which is a one-to-one remote consultation with Vicky. And I have just popped some contact details on the slides here for you as well. So do feel free to make a note of those. If you've got any questions at all after today on larval therapy, we can certainly do our best to help you. And we are on every form of social media you can possibly imagine. So do please come and say hello there. It would be great to connect with you. But thank you. A huge thank you to Leanne. It's been a wonderful session this evening. I've thoroughly enjoyed it. And thank you to Vicky as well for coming on for those questions at the end. And a huge thank you to everybody at home. I really hope you've enjoyed, and we'd love to see you again on another BioMonde Live in future. Good evening, everybody.